Hello everyone, my name is Hiranyada and today I'll be covering the topic of spleen pathology. This question includes splenomegaly, splenic rupture, and other circulatory disorders related to the spleen. So before I discuss the disorders related to the spleen, I would first like to focus on the anatomy and the function of the spleen. So if you guys focus here on this diagram, this is the spleen, and it is surrounded by a capsule, which is a capsule made of thin connective tissue. There are invaginations of this capsule, and you can also see that there are sinusoids, which are made by the arteriole and the venule. And in between them, you have the stroma, which is made up of reticular connective tissue and fibers. The spleen is further divided into two parts. We have the red pulp and the white pulp. The red pulp consists of the sinusoids, the splenic cords, and the reticular meshwork. The sinusoids are basically capillaries made of stave cells. Stave cells are nothing but elongated endothelium. And we have the splenic cords, which are also called as cords of Billroth. This comprises of the reticular connective tissue, macrophages, and red blood cells. As for the white pulp is divided into three zones. So it sort of looks like a small tree or a leaf. So the outermost zone, also called as the marginal zone, comprises of the B cells and the macrophages. The middle zone or the mantle zone comprises of follicular B cells, and the germinal center too comprises of follicular B cells. There is also a space over here around the artery, which is called as the periarteriolar lymphoid sheath, also known as PALS. And over here you can find T cells. Now, the spleen has a few very important functions. One of the most important function is blood filtration. The macrophages in the spleen remove the old red blood cells. Along with that, it plays a role in the immunity where it has the antigen presenting cells, the B cells, and the T cell activation proliferation. It is also a blood reservoir and is also responsible for extramedullary hematopoiesis. It is seen in case of fetal development or in case of bone marrow related pathology when there is decreased production. So, in order to compensate for that, extramedullary hematopoiesis occurs in the spleen. So this was about the function and the anatomy of the spleen. Now we divide splenic disorders into two parts. We have the non-cancerous diseases and the tumors. The tumors are almost extremely rare, especially the primary tumors. And for non-cancerous diseases, these are the ones that are more common and most often seen. So we'll start off with the first one. The first one being splenomegaly. Now, splenomegaly is the increase in the size and the weight of the spleen. Physiologically, the spleen weighs around 70 to 200 grams, and an increase of up to 400 grams or 500 grams or more, then we call it as splenomegaly. Also, apart from the weight, we also check if the spleen is palpable or not. Usually, in normal cases, the spleen is not palpable. If it's palpable, then we should consider it as a pathology. What are the causes of splenomegaly? The most important cause here to mention is the congestive splenomegaly. Congestive splenomegaly happens due to venous flow obstruction, which causes a passive pooling of blood within the spleen. This can be due to right sided heart failure or portal hypertension, and can even be due to portal vein thrombosis or any kind of cancer, such as stomach cancer or pancreatic cancer. Before I move on to the next cause, I would like you guys to focus here on the picture below and this particular text. So, in congestive splenomegaly, because there is venous congestion as the outflow of blood has been obstructed or stopped, what we see an enlarged spleen, and along with that, the spleen appears to be cyanotic and indurated because of pooling of the deoxygenated blood. So if you look here on the picture, the spleen appears to be enlarged, and along with that, it appears slightly cyanotic. Microscopically, not that important, but there is dilation of the sinuses due to the pooling of blood. And in the case if it's chronic, there is fibrosis of the capsule. So the capsule surrounding the spleen is fibrosed. Moving on to the next cause, splenomegaly can also be due to increased sequestration of blood elements, and that can be seen in cases of thalassemia or congenital spherocytosis. That is when there is an increased destruction of the red blood cells. The third cause is in the case of acute and chronic infections. Since spleen is an organ which is responsible to, which is a lymphoid organ, in that case, in any kind of infection, the activity of the spleen will be increased. So when the activity of the spleen is increased, there is also an increase in the size. So this can be seen in diseases such as malaria, leishmaniasis, infectious endocarditis, HIV, infectious mononucleosis, tuberculosis, and even in patients who are septic. A point to note here is that macroscopically, in case of infections, the spleen usually appears enlarged and is soft and mushy. Abscesses of the spleen are extremely rare. The fourth cause is non-infectious inflammations, which include autoimmune diseases such as sarcoidosis, rheumatoid arthritis, and lupus. Now, there are two sets of infiltrative diseases that can cause splenomegaly: the non-neoplastic infiltrative diseases and the neoplastic ones. As for the non-neoplastic, the most important example is extramedullary hematopoiesis that I mentioned above, when due to some pathology in the bone marrow, the spleen resumes its hematopoiesis. Along with that, there are metabolic storage disorders and amyloidosis. With tumor diseases or neoplastic infiltrative diseases, we need to remember that lymphomas and leukemias also present with splenomegaly, and and also other myeloproliferative disorders. And as for the last point, there are certain storage diseases which are also part of the metabolic diseases, such as the Gaucher syndrome or the Niemann-Pick disease, which are autosomal recessive diseases. These diseases cause accumulation of the lysosome, and because of that, we observe splenomegaly in the patient. So this is about an enlarged spleen. Moving on to this blue colored table. Now, we've discussed the possible etiologies of splenomegaly. Here, we need to remember that splenomegaly has three classifications. It can be light, which means that it is less than 500 grams. It can be moderate, which means that it is between 500 and 1000 grams. Or it can be massive, which means that the enlargement is more than 1000 grams. Here are the examples or the causes for each of the light, moderate, and massive. And it would be great if you guys could remember a few examples from all the three columns. Moving on to the second kind of disorder. The second set of disorders is associated with the developmental disorders. And over here, we focus on asplenia, which is absence of the spleen, which is extremely rare. And a patient will present with symptoms similar to similar to a patient who's had splenectomy or has a splenic dysfunction. The patient can also have accessory spleens. This is relatively more common, and they can be up to 4 centimeter in size. And it is important to know that accessory spleens usually don't have any particular symptoms, and they're often an incidental finding in the splenic hilum or in the pancreatic chorda. The next one is splenic rupture. Rupture of the spleens, splenic rupture's common etiology is trauma, and because of this, it can lead to hemorrhagic shock due to extensive bleeding. The fourth is splenic infarction. Now, infarction happens when there is a loss or obstruction of blood supply to a particular organ. And this happens whenever there is an embolism or thrombosis of the splenic artery. This also can lead to secondary hemorrhages. Now, the emboli can be from the heart. If you look here on the corner of the picture, it can either be a bland infarct or it can be a septic infarct. A bland infarct is basically a thrombus which is embolized from the heart and is made up of fibrin. It makes the spleen look pale and it is subcapsular. Whereas a septic infarct is a thrombus which is embolized from the heart but is usually infected. It could be infected with some kind of bacteria or maybe a fungal infection. And in this case, you will see suppurative necrosis of the spleen. Suppurative meaning that there is formation of pus, and necrosis meaning that the tissue is decaying. As for the morphology, all of us know that whenever there is infarction and ischemia, we see a wedge shaped infarction, so sort of like a triangle. The fifth point that we need to know is about the spleen being in inflammation. So this disorder is when you have a severe infection or the patient is in sepsis, which causes activation or sometimes maybe overactivation of the spleen. This leads to an enlarged spleen. So it basically goes hand in hand with your splenomegaly. And as I mentioned before, that the spleen appears to be very soft and mushy. The last and the sixth point for non-neoplastic disorders of the spleen is hypersplenism. Before I discuss this in further, you must note that there is a difference between splenomegaly and hypersplenism. Hypersplenism is an increase in the function, whereas splenomegaly is an increase in the size. So a patient with hypersplenism will usually have splenomegaly, but a patient with splenomegaly might not necessarily have hypersplenism. So as we discussed before that the function of the spleen is to sequester and destroy the blood elements. So if there is an increased function, that means RBCs, WBCs and platelets all are getting sequestered and destroyed. If this function happens happens excessively or the spleen is in overdrive, then what happens is that a destruction of the RBC will cause anemia in the patient, destruction of the WBC will cause leukopenia in the patient, and destruction of platelets will cause thrombocytopenia in the patient. A patient with hypersplenism again will present with splenomegaly, peripheral blood cytopenia, as I mentioned here before, and also a compensatory reactive bone marrow hyperplasia to replace all of these lost cells. The treatment for this particular disorder is a splenectomy. Moving on to the tumors. The tumors essentially are not a part of this question, but it is important that you know a little something about them in case the professor asks you. So, tumors of the spleen are usually secondary rather than primary. For primary tumors, they are mostly benign and vascular. They are hemangiomas or can be littoral cell angioma or hairy cell leukemia. But as I said before, that the secondary ones are more common. So we most often see leukemias or lymphomas, or there is a solid metastatic spread of the tumor from a melanoma or lung carcinoma, pancreatic cancer, or liver carcinoma. Before I end this lecture, there are two important points that I'd like you to note. And these are the points which tell us about the signs of splenic dysfunction. So whenever a patient presents with splenic dysfunction, what do you see? First of all, we see the Howell Jolly bodies. These are bodies which are essentially RBCs which have nuclear remnants in them. So in a peripheral blood smear, you would see RBCs with small nuclear remnants within them. And The second point that is important to note is that there is an increased risk of infections by encapsulated bacteria in case of splenic dysfunction. The spleen has the ability to fight with pathogens that are encapsulated, namely Haemophilus influenza, pneumococci, and meningococci. So, in case of the dysfunction of the spleen, the body will not be able to fight these, and this will result in an increased infection by these pathogens and also an increased severity of infection by these pathogens. The possible mechanism and the reasoning for this is that because of splenic dysfunction, there is a decrease in the IgM antibody production, and that leads to a severe and more common infection. Along with that, there's also a decrease in the complement system activation and also a decrease in macrophages. The decrease in the macrophages is explained by the loss of the tuftsine factor, which is a factor synthesized in the spleen that is responsible for activation of the macrophages. So this is just a short summary of the bland and the septic infarcts and about the signs of splenic dysfunction. So yeah, that is all from my side about this particular question. And thank you guys for your attention and see you in the next one.